The 6 stages of stroke hemiplegia rehabilitation. Stage 1. Flaccid stage, acute phase. Characteristics. There is no voluntary movement in the affected limbs. Muscles are flaccid, and reflexes are absent. The limbs feel limp like noodles. Rehabilitation focus. Proper positioning. Good limb position. Maintain correct lying postures to prevent joint dislocation, such as shoulder subluxation, and pressure sores. Passive range of motion. A family member or therapist helps move each joint through its passive range to prevent joint stiffness and muscle atrophy. Turning training. Begin practicing turning from side to side in bed as early as possible. Stage 2. Initial synergies and associated reactions. Characteristics. Muscle tone on the affected side begins to increase, showing signs of spasticity. When the healthy side exerts effort, involuntary muscle contractions occur on the affected side, associated reactions. Alternatively, the affected limb can only perform gross, synergy pattern movements, limb synergies, and cannot isolate individual joint movements. Rehabilitation focus. Utilizing associated reactions. Use associated reactions to induce subtle movement in the affected limb. Passive range of motion and balance. Continue strengthening passive motion exercises and sitting balance training. Stage 3. Severe spasticity peak. Synergy reaches peak. Characteristics. Spasticity becomes very pronounced, with significantly elevated muscle tone. The upper limb typically presents in a flexion pattern, clenched fist, bent elbow pulled tightly against the chest, while the lower limb exhibits an extension pattern, stiff leg, inward turning of the foot, circumductive gait. The patient can voluntarily initiate synergistic movements, but cannot break free from these fixed patterns. Rehabilitation focus. Control and reduce spasticity. Manage high muscle tone through stretching, heat therapy, or medication. Break synergistic patterns. Practice isolated subtle movements that break out of the fixed patterns, e.g., reaching with an extended upper limb, opening the palm. Standing balance training. Begin targeted exercises to improve balance while standing. Stage 4. Partial separation movement. Spasticity begins to decline. Characteristics. Spasticity starts to ease, allowing the patient to gradually break free from synergy patterns and perform isolated movements, independent movement of individual joints. Upper limb examples. The hand can touch the lower back. The arm can raise forward to 90 degrees while keeping the elbow straight. Lower limb examples. While seated, the sole of the foot can lie flat on the floor and slide backward to flex the knee past 90 degrees. Rehabilitation focus. Train isolated movements. Intensify practice of separated joint movements to enhance motor coordination. Fine motor skills and gait. Focus on fine hand controls, such as gripping and releasing objects, and stepping exercises. Stage 5. Advanced isolation movement. Spasticity significantly reduced. Characteristics. Synergy patterns have largely disappeared, making complex movement combinations easier to perform. Actions appear much closer to normal, though speed and fine motor skill may still remain somewhat clumsy. Upper limb examples. The arm can be raised straight overhead. The arm can be abetted laterally to 90 degrees. Lower limb examples. Ability to flex the knee and dorsiflex the ankle, pointing toes upward while standing. Rehabilitation focus. Fine motor skills training. Practice daily functional activities like unbuttoning clothes, holding chopsticks, and writing. Functional mobility. Focus on improving walking speed, endurance, and practical gait stability for daily life. Stage 6. Near normal function. Characteristics. Synergy patterns are completely gone, and muscle tone is entirely normal. Individual joint movements are fully free, with speed and coordination approaching the healthy side, normal levels. A slight lack of agility may only appear during exceptionally rapid or highly complex activities. Rehabilitation focus. Complete independence. Maximize full self-reliance in all activities of daily living, ADLs. Vocational and social integration. Engage in occupational rehabilitation and training aimed at returning to social and professional roles. Core rehabilitation reminders. Golden recovery window. The first 3 to 6 months post-stroke represent the golden window for functional recovery. Rehabilitation should begin as early as possible once the condition stabilizes, typically 2 to 3 days after an ischemic stroke, or 1 to 2 weeks after a hemorrhagic stroke. Step-by-step progression. Rehabilitation is a gradual process. You must walk before you can run. For example, forcefully pushing walking exercises during stage 3, when spasticity is severe, will only reinforce incorrect walking mechanics, such as a circumductive gait pattern. Individual differences. Not every patient progresses through all 6 stages. The extent of recovery depends on the site and size of the brain lesion, as well as how early and consistently rehabilitation is undertaken. Thank you for watching.